My name's Samantha Davis. Today's the 23rd of September. This video will show 6 airway skills. They are insertion of an OPA, insertion of an NPA, laryngoscopy, the lateral side roll, BVM ventilations and the triple airway manoeuvre. Standard precautions of gloves and goggles will be used for all of these skills. So this is the lateral side position. This helps keep the conscious patient with a pattern airway. It helps keep their airway open. To do this, we place a towel beside the patient's head on the side that you're going to roll them to, and just have a quick check of their pockets, make sure there's nothing sharp that they could roll onto. Then we take their far arm and place it on the right angle to their shoulder, and then the arm goes across their chest. Then you lift up their near leg at the knee and bend it. Then you take a grip on their shoulder and their hip and gently roll them onto the towel. A common error is to forget to move this knee up into the right angle, but by doing this we stop the patient from falling onto her face and occluding the airway. Then we place this arm just in front of her face and check that her airway is open and she's still breathing. Now I'm going to demonstrate how to insert an NPA. The indications for this is an unconscious patient with trismus, and contraindications are nasal trauma and patients with middle third facial fractures. Precautions are basal skull fractures and CSF leaking from the nasal ears. To prepare the patient, you need to manually check the airway and perform the triple airway manoeuvre and attempt to insert an OPA. If the OPA cannot work because of the patient's trismus, you measure the NPA from the base of the nose to the earlobe. Then you put KY jelly on to make it easier to insert. Lift the nose up towards the eyes and select the largest nostril. You then rotate the NPA 45 degrees clockwise to anti-clockwise until it's inserted. A common error is selecting a NPA that is too large and inserting it the full way, which will cause nasal trauma at the back of the nose. When a patient has a foreign object obstructing their airway, it needs to be removed. To do this, we use a laryngoscope and the McGill's forceps. Contraindications for the laryngoscope are someone with a gag reflex, and indications is someone with an obstruction in their airway that can be seen, so it's not past the vocal cords. To prepare the patient, we place a pillow behind their head and maintain a neutral sniffing position. Our laryngoscope is on the left and suction equipment and McGill's are on the right to clear the airway. We need to check that the light bulb is working and it's secure on the laryngoscope, and pick it up in our left hand with the curve pointing towards the patient's chest. We insert the laryngoscope down the right side of the patient's mouth and move the tongue to the left whilst lifting upwards. We pick up the McGill's forceps with our right hand and insert into the patient's airway, and when we're within 2 centimetres of the foreign object, we open the McGill's and remove it from the airway. Now that our patient's airway is clear, we can insert an OPA to aid with their breathing. Indications for this are an unconscious patient who needs help ventilating, or to use as a bite block to insert an ETT. The contraindications are a patient with trismus and also a patient with a gag reflex. We measure the OPA from the corner of the mouth to the angle of the jaw, and we just need to double check that on both sides that it is the right side. A common error is using an OPA that is too big, like this one, as it will cause damage to the back of the throat. Before inserting, you need to open up the patient's airway and lubricate their mouth with either some water or their own saliva. We insert the OPA with the curve facing up towards the roof of the mouth, and once it's halfway in, rotate 180 degrees and insert it all the way. This will stop the tongue falling back to the back of the throat and obstructing the airway. When a patient isn't breathing properly, we need to provide them with positive ventilations. To do this, we insert an OPA and place a patient in a supine position and stand at their head. Select an appropriate size BVM, and in this case it's an adult size, and roll it on over the nose and mouth, ensuring an adequate seal. We want to provide 12 breaths a minute to our patient. As you can see, the chest is inflating, which means that there is an adequate seal, but a common error is having an inadequate seal, which will not provide adequate ventilation to our patient. Now I'm going to do the triple airway manoeuvre. To prepare the patient, we place them in the supine position with the towel under their head. The first step of this is to manually clear the airway and suction if necessary. We then have to perform the head tilt and chin lift to open the mouth. To do this, we place the right hand on their forehead with our thumb facing forward and the chin between our thumb and index finger of our left hand. We then apply pressure on the forehead and lift the chin vertically. This is called the sniffing position, and to perform the triple airway manoeuvre, we then have to add a jaw thrust. So we place the 5th, 4th and 3rd fingers on the angle of the mandible, and our index fingers on the body of the mandible, and our thumbs on the zygomas. We then apply pressure at the angle of the mandible and thrust the jaw forward and lift the head up. A common error of this is hyperextension of the neck, which will cause a kink in the airway.